Okay. السلام على الجميع. Good evening everyone and thanks for joining us today. I am Dr. الشكرجي, adult neurologist at Meena Teaching Hospital and senior lecturer at Muslim Medical College in Iraq, of course. And it's my pleasure to welcome you to our educational webinar series organized by Iraqi Stroke Network. All our webinars are endorsed by Meena Stroke Organization. This is our 15th educational webinar on stroke management in the ICU. Over the next 60 minutes, inshallah, we will explore some of the most significant development in stroke care at ICU, discuss emerging challenges, and consider how these innovations are reshaping patient care. Whether you are a neurologist, internist, intensivist, or other healthcare worker, I hope you will find today's discussion both informative and inspiring. Today we have a one-of-the-kind expert in the field of neuroanesthesiology. He will talk about a very important topics in acute stroke care. Before we dive in, I leave the word to our panelist, Dr. Zainab Ali Mukheef, a consultant anesthesiologist and intensivist. Dr. Zainab is the head of anesthesiology department and ICU in Diwani Teaching Hospital. She is also the head of training center of anesthesiology and intensive care of Diwaniya. The word is yours, Dr. Zainab.
Thank you very much, Dr. Ramadan Kareem على الجميع والسلام عليكم. It is honor to be to me to be one of this group who are discussing this great subject, and I want to express my pleasure to be part of the team of stroke unit in Iraq in general, and especially in Al-Diwaniya Teaching Hospital. This I consider, or it is really a great jump in healthcare, providing the opportunity to have a normal life for those patients who suffer from acute stroke. And now, as you know, maybe we treated a lot of many patients by Dr. Mustafa Kareem. And all are admitted in the ICU in Al-Diwani Teaching Hospital with very, very beautiful results. And I am really eager to share with you or to listen for your experts and or your acknowledgement about providing the best care for those patients in ICU. Thank you very much.
Thank you, ma'am. Thank you. The question and answer section will be led by Dr. Meena Abdulfattah. Dr. Meena, you have the word now.
السلام عليكم ورحمة الله. رمضان كريم على الجميع. I am Dr. Meena Abdulfattah Nouri, Senior House Officer in Neurology in my first year of training of Iraqi Board of Medical Specialization. I will be with you at the question and answer section at the end of the lecture. Dear doctors, anyone has a question, you can write it in the chat box, or you can simply raise your hands. There will be time for discussion at the end of the lecture. Thank you.
Thank you, Dr. Meena. Thank you. Our speaker tonight is Dr. Mazen El-Wishi. Dr. Mazen is a consultant in neuroanesthesia and neurocritical care. He has special interest for interventional radiology anesthesia. He published several papers and book chapters in the field of neuroanesthesia. Dr. El-Wishi worked at many NHS Trust Hospital in UK before moving to the UAE. He had his basic medical education at Ain Shems, Cairo, Egypt. The floor is yours, Dr. Mazen.
شكرا دكتور علي. شكرا دكتور مصطفى للدعوة الكريمة ورمضان الكريم عليكم.
علينا وعليكم إن شاء الله.
إن شاء الله. أنا هبتدي أعمل شيرنج للسكرين. أنا التوبيك اليوم اللي هتكلم عليه زي ما اتفقت مع الدكتور مصطفى هو it's mainly يعني about management of stroke في الانتنسيف كير. بس أنا حبيت برضو إن أنا يعني بما ان انا انستيزيولوجيست فانا لازم اتكلم على الانستيزيا. وكمان دكتور مصطفى كان قال في hopefully some of the participants in the meeting will be anesthesiologists, this will be very relevant to them as well. What I will try to do during this presentation is to just give you a little bit of a glimpse about intravascular thrombectomy and the process that this involves the controversies regarding the mode of anesthesia. Just very briefly go on to the initial management and ICU management of these cases. I would apologize if some of the slides will be a bit basic for some of your expertise within the participants, but I would hope you would bear with me, because maybe some of the attendees of this webinar might be junior doctors that might benefit from this as well. So if some of the information is a bit too basic, please bear with us as well. Okay, so if you want to know what an endovascular thrombectomy is from the very basic understanding, there are lots of like resources and videos on YouTube to show you what actually an endovascular thrombectomy is, just what the process is. One of the videos is like from the Cleveland Clinic. It's a very good video. You can watch it on YouTube. But to give you some of the just basic understanding. So it's for a thrombectomy, when your patient presents with a stroke, interventional radiologist will put the catheter via the femoral artery, and that catheter will just go through the femoral artery all the way up to the aorta, through the arch, and then via the internal carotid artery into the cerebral circulation. And once the stroke is, or the clot causing the stroke is found, can be either sucked away or can be entangled with a stent retriever. And then the clot will be removed and circulation will be restored. So this will be a very simplistic way of looking at what an endovascular thrombectomy is. And this is an actual clot that looks, this is a picture that I personally took of a clot entangled in a stent retriever. What's the evidence behind endovascular thrombectomy? There's very good evidence. I mean, we are beyond thinking whether this is a beneficial treatment or not. We know for sure that it is. If you compare it to medical treatment alone, you will get significant reduction in disability and mortality when compared to medical management, with an odds ratio of 2.49. And in terms of the anesthesia, there has been a lot of controversy about the optimal mode of anesthesia. When the initial papers came out with the benefit of endovascular thrombectomy, a lot of papers came out comparing the outcomes of general anesthesia versus conscious sedation. And the papers that were published at the time gave a very bleak pictures of what general anesthesia does. And it was then deemed that general anesthesia is extremely harmful to patients. I do remember when I was still in training that if thrombectomy came through the door and you wanted to put the patient to sleep, the interventional radiologist will just ask you, what are you doing? Are you trying to kill the patient or harm them? It's like, no, I'm just trying to keep them still so you can do your operation. But the belief was very much embedded that general anesthesia was extremely harmful. And one of the papers that came out to argue that was one of the most cited papers, which is the paper published in the American Journal of Neuroradiology. And I'm not sure if you can see my mouse here. So you can see this is one of the main tables that came out of this, that basically told that if you have a general anesthesia, you had an odds ratio of 2.59 of death. So you're more than 2 times likely to die if you have a general anesthetic. But the problem with this, that this was actually not patients that have been randomized to receive either general anesthesia or conscious sedation. These are actually retrospective analyses. So the general anesthesia was actually, and not the cause, but it was the effect of how sick these patients were. So the most sick patients were the ones who actually received the general anesthesia. And that's why their outcome was much worse. And as you can see from the same table, the odds ratio of successful recanalization, which any anesthesiologist in the audience will know has got nothing to do with anesthesia. So successful recanalization will not be affected by whether you give them a general anesthesia or a conscious sedation. But your odds ratio of getting a successful recanalization is much worse than general anesthesia, and that gives you an idea. These patients had more deaths and more poor outcomes because they had less successful recanalization, not because they had a GA. So all of these papers, none of these had any anesthesiologists involved in writing the papers. None of them actually described what the anesthesia mode was or what kind of anesthetic drugs were used or anything. So there was massive bias in these papers. And I think most anesthesiologists who were working within the field knew that this was not correct, despite all the evidence out there. So when some group of anesthesiologists actually did some papers on this, there was some three main papers that came out in the last 5 to 10 years. And these were the Siesta and the Stroke and the Goliath trial. And these were patients who were randomized to have a general anesthetic or a conscious sedation, with everything else being equal. And when they compared them they sort of did a meta-analysis pooling all of the results together, they actually found that your chances of getting an MRS of 2 or less was about almost 50% in patients who received the general anesthetic. But if you had the conscious sedation, you'd be about 35%. So I think this just proved what I think most people in our field knew, that general anesthetic is actually much better for these patients. I'm a strong believer about giving general anesthetics to these patients because it makes the life of the intervention radiologist so much easier, and the operation or the procedure can take much less time if you provide a patient who's very still and stable, who can have the procedure done quickly. So again, going back to the idea that this was, some of this might be very basic information, but just to remind everyone what are the risk factors that these stroke patients have. And this gives us an idea of what patients will be facing in our sort of interventional radiology rooms or in the ICU. So the majority of them would usually have a higher age group, but some of them come in at the younger age. But this is like a different cohort of patients under the young stroke. They're usually hypertensive, diabetic. A lot of them will come in with atrial fibrillation. The other risk factors would be things like high cholesterol, smoking, alcohol excess, obese patients. Migraine is also a known risk factor for getting a stroke. So when the patients do arrive, the initial assessment, hopefully either like an in-hospital or out in the community, they say about FAST, so face, arm, speech, and then time to call for help. Would also use your regular assessment methods like an ABC approach, like airway, breathing, circulation. You take a history from the patient. You do an examination that will involve an NIHSS score. You would think about the stroke mimics, and then you will obviously do some definitive management by starting with a imaging, like a CT brain plus or minus a perfusion. This is like a list of the stroke mimics that you have to think about before you jump in giving any treatments. And then a CT brain or a CT perfusion. I am not a radiologist, so I'm not going to go into deep details about how to interpret a CT perfusion. Maybe some of the audience might be in radiology, but a very brief explanation to what a CT perfusion looks like. On the left-hand side of the screen, this is like an interpretation of a CT brain with contrast. This one represents the cerebral blood volume, and the cerebral blood volume is just the amount of blood that is present in the brain tissue within that slice at a certain time. And on the on the right-hand side is the cerebral blood flow, which is obviously the rate of flow of blood in a certain time frame. And if you see on the cerebral blood volume slice, there is symmetry between two sides, and there's no obvious reduction of volume in any particular areas of the brain. So that means that there is an actual preservation of the cerebral blood volume. But on the same slice, when you look at the cerebral blood flow, you can see that the cerebral blood flow is reduced significantly on the right side. Sorry, on the left side. And this is what they call a mismatch. So when you get a mismatch between the cerebral blood flow and the cerebral blood volume, this is an indication that you have a part of the brain tissue which is compromised. It is still getting perfused by collateral circulation, but the main blood flow is compromised. And this is a patient who is eligible for a thrombectomy and will probably have a good amount of brain tissue to salvage. And these are the patients who would hopefully do very well after you take the clot away. Again, this is a very simplistic view on CT perfusions. It's much more complicated than this, but this is how I look at it. And usually this is how I explain it to the residents and the juniors that come through to do their neuroanesthesia modules. And following from this, it is extremely important in any institution that does stroke management and stroke thrombectomies to have a process in place. And I have seen this in the hospitals of different hospitals I've worked in. The process is, once you get the process right, the outcome is much better for the patients. Because as we know, time is brain. So you need to minimize any time delays before getting the patient to have either the thrombolysis or the having first the CT scan, having the thrombolysis, and if they're eligible for thrombectomy, to have the thrombectomy done as soon as possible. So from the referral of the patient, they go to the emergency department. They have the CT scan. Once a stroke or a ischemic stroke suspected, the case should be immediately discussed with the stroke physician and then with the interventional neuroradiologist. Once the decision to proceed for thrombectomy is made, then the anesthesia staff should be mobilized immediately. And the patient would then arrive into the angiography suite. Handover should be given by the stroke team about the general history of the patient, so that the anesthesiologists do not waste time trying to gather information about the patient from like family members or whatever. And then we'll talk about post-anesthesia care, which is obviously the main reason why we're having this talk about the post-anesthesia care. And this will be like a handover sheet that I had worked with our stroke physicians to devise this piece of paper that should basically covers some basic information that will be relevant to all the team members looking after the stroke patient. In terms of anesthesia, again, this is very anesthesia specific. Apologies to anyone who is not interested in this part, but what I'm trying to say out of this is you should keep things very, very simple. Right. This is a very simple anesthetic, and the most important thing here is to keep the patient still and be very quick. So I would put everyone to sleep, give them a few drugs, get them off to sleep, but then I would give them some medications like vasopressor medication to keep their blood pressure up, and then get this operation done. The blood pressure targets is extremely important during and after the procedures. We should aim to keep the systolic blood pressure between 140 to 180. The majority of these patients will be hypertensive. If for any reason you get this old patient that is hypotensive on admission, then you should at least keep their blood pressure at baseline. When you finish with the procedure, just assess the airway. Again, if you're going to do some suctioning, be very careful because the patients usually have been thrombolized. Some of them would need the urinary catheters, especially if they're old males with large prostates. You don't want them waking up with extreme agitation because of a full bladder. So you might want to consider having a urinary catheter before waking them up. So the majority of the patients in the institutions that I've worked in would go to a recovery room for 1 hour, and then they'll be discharged to stroke unit, and then some of them will be admitted to ICU if required. So what about ICU management? So ICU management mainly is aimed at minimizing any secondary brain injury. And this includes things like brain edema or progressive stroke. You want to monitor them from a hemodynamic and a neurological point of view, trying to maintain as normal physiology as possible. So to know how to minimize secondary brain injury, you need to know all of the things that are basically harmful to the brain. If you know what is harmful to the brain, you'll try to avoid it or to correct it. And you will hopefully then provide the patient with the best outcome following thrombolysis or thrombectomy. So this is what I will do. You'll find that the majority of what I'm going to be speaking about for the next 10-15 minutes is extremely simple measures. It's not rocket science here. It's all very simple things, but it's more about remembering all of the things, because if you do one thing and forget about the others, you are obviously not providing the best care for the patient. The patients who are usually admitted to ICU, it's about institutional variability. I think Dr. Zainab said that the majority of the patients in the hospital that she works in go to ICU. This is the case in a lot of hospitals worldwide, but also some of the hospitals do not admit all of the patients to ICU. They would then, especially if they have pressures on ICU beds. So a lot of the patients would go to a stroke unit, and there will be some select patients that will go to ICU. And these patients will be particularly patients who have either established or impending neurological deterioration that need to be monitored in ICU and looked after. Some of these patients will need intensive blood pressure management. Like I said, a lot of the patients coming in post stroke will be extremely hypertensive, and some of them will need like continuous intravenous medications to control the blood pressure with close monitoring of the blood pressure as well. If the patient is post thrombectomy, sometimes some of these patients have vascular complications from the femoral axis, like groin hematomas or ischemic peripheral circulation in the legs. And some of them will need to be admitted to ICU for monitoring for vascular complications. So this will be the majority of admission criteria for the patients post-stroke in the hospitals, which do not admit all patients to ICU post-stroke. So in terms of, like I said, we're going to go bit by bit about the minimizing the secondary brain injury for patients. And I repeat again, none of the upcoming things are going to be revolutionary. They're going to be very simple things, but I'm just reminding you of what to look for. So the first things are airway management and ventilatory support. You would aim to obviously provide the patient with oxygen, trying to maintain the saturation above 94%. If endotracheal intubation is indicated, then obviously they will need to be intubated and ventilated on ICU. Usually the indications for that would be a reduction of Glasgow Coma score less than 8. Or the patients with a Glasgow Coma score less than 8 will be patients who are unable to maintain their own airway and will be at risk of aspiration and respiratory failure. Some patients are admitted with respiratory failure from the start. If a patient has a posterior circulation stroke, they would have brainstem dysfunction and they will have problems with controlling their own breathing. So they will then require intratracheal intubation and ventilation on ICU. While the patients are on ICU, you need to do an early swallow assessment, obviously if they're not intubated, just to avoid aspiration. So some of the patients will have oropharyngeal dysfunction as part of their stroke presentation. So you don't want these patients to start also obviously eating and drinking and then aspirating and then running into problems with the respiratory function after this. So an early swallow assessment is crucial for these patients before attempting to obviously start feeding. So that's one thing. So oxygen, obviously, so that's the first thing we've acknowledged that is harmful to the brain, which is hypoxia. Hypoxia is very harmful, so you need to avoid it. The other thing is fever. Fever is very harmful to the brain as well. So any fever, which is defined as a temperature above 38 degrees, should be treated very aggressively. So you should not wait for this to get any higher or before you start acting. So you need to treat them immediately with antibiotics. And if you suspect that patients have any infective sources like a urinary tract infection or like a pneumonia or any sort of infection, they should be investigated and treated immediately with the appropriate antibiotics and appropriate management. So hypoxia, temperature. The other things are obviously hypotension and hypertension. Again, harmful to the brain if not well controlled. So if you have hypotension, this is not very common in patients with post-stroke. I have to say, I don't think I've seen any patients coming with hypotension. But obviously they do exist. So if a patient presents with hypotension and hypovolemia, you need to correct it. You either need to give vasopressor drugs or inotropic drugs. You need to provide fluids to maintain systemic organ perfusion. But like I said, again, this is not very common. The most common thing would be hypertension. If a patient has had a thrombolysis and or a thrombectomy, it is recommended by the European Stroke Organization and the American Heart Association to maintain the blood pressure less than 185 or over 110. 185 systolic, 110 diastolic for the first 24 hours. After 24 to 48 hours. After that time, you should aim to treat hypertension as you would normally do in the community. So you would aim for whatever blood pressure targets are the norm at this time, and I think that would be a systolic of 140 and below. If patients have not received thrombolysis or thrombectomy, the targets for the blood pressure are much more relaxed. So you would allow the patients to have a blood pressure all the way up to 220 to over 120. And you should not treat the blood pressure if it's less than that. So if the blood pressure is 210 over 110, you should allow it to stay at that level. Remember, some of this will be a normal physiological response for the brain to try and perfuse any areas of brain tissue that are sort of hungry for that blood perfusion. And if you start reducing that blood pressure acutely, then you run the risk of turning an area of the brain that was still perfused into an ischemic core, and you would then risk causing progression of the stroke. So the European Stroke Organization and the American Heart Association recommend that the blood pressure, anything less than 220 over 120 is left alone for the first, again, 24 to 48 hours. And if it is higher than that, then you should aim for like slow reduction, not acute reduction. So you would reduce it gradually by about 15%. And the drugs to use for that is whatever you have in your organization. It's usually things like nicardipine, labetalol, hydralazine, whatever you have at your disposal will be used for reduction of the blood pressure. Again, same thing applies. After 48 hours, you should try to treat the blood pressure as you would normally do in the community. So we've established what we do with the blood pressure. Again, other things that are harmful to the brain is hyperglycemia and obviously hypoglycemia. But hyperglycemia, again, is the most common thing that patients present with. Like we said, patients are usually a big percentage of them will be diabetic, and they will have diabetes that's out of control at this time. So you should try to aim for normal glycemia. So you would monitor these patients' glucose on regular intervals, and obviously treat accordingly, either with insulin or whatever is required. In terms of long-term treatment with antiplatelets, antithrombotics, there is a big variability in what is required for each patient, and the variability happens with the stroke severity. So the treatment for minor stroke and the TIAs is different from patients with moderate or severe stroke. If the cause of stroke is cardioembolic, the treatment for that is different to causes of stroke that are from different sources. Also, the risk of hemorrhage does play a part in whether you start them on antiplatelets or antithrombotics and when you actually start them. So this is a very complex topic, and that could be a discussion, like a topic for discussion on its own. That could take hours to discuss. I'm not going to go into details of this. But what I would say, and this is what I would usually tell the residents or the people that I work with, obviously discuss with the neurology team, because they will obviously have the better knowledge of which patients need which treatment at any specific time. If a patient is expected to be immobilized for long periods of time because of the stroke, then they would recommend using intermittent pneumatic compression devices like those like calf compressors, just for reduction in the rates of deep venous thrombosis in lower limbs. In terms of other things that you need to be aware about, and again, other things that you want to avoid causing further damage to the brain, is hemorrhagic complications. So hemorrhagic transformation in stroke is obviously is a serious complication. It needs to be avoided if possible, and treated promptly if it does happen. The most reliable predictor of hemorrhagic transformation is obviously the infarct size. So the bigger the infarct, obviously the larger risk you get with hemorrhagic transformation. If you do have a symptomatic intracranial hemorrhage, so this is a patient who has intracranial hemorrhage that actually presents with either reduction in the Glasgow Coma scale or new lateralizing signs, then and it happens within the first 24 hours of thrombolysis, then you would try to treat it as promptly as possible. The recommended treatment is usually with cryoprecipitate, because what you want to do in these cases is provide them with fibrinogen. You've given them fibrinolysis, so you've taken away that function of clotting. So you want to provide them with fibrinogen to be able to clot again. You can give them tranexamic acid again for the same purpose. And once you reach a stage where you get a symptomatic intracranial hemorrhage, then it is reasonable at that stage to maintain the blood pressure less than 140 acutely, because what you want to do is to reduce the amount of bleeding into the stroke tissue. So you would then be expected to reduce the blood pressure at this stage. Then, obviously, the other thing which is not very uncommon is brain swelling. So you want to be able to treat that as quickly as possible if it does happen. And that is only if it is obviously a patient who would be eligible or would benefit from the reduction of brain swelling. Because remember, some of the patients that would have like devastating strokes, and some of them will not be eligible for further management with decompressive craniectomy or similar things. So you would have to obviously make sure that you choose the treatment correctly for these patients. So if you are going to use means of managing brain swelling, you have to obviously choose the correct patients, because if you're going to use hyperosmolar agents like mannitol or hypertonic saline, you have to remember that this is only temporary measures. So they're only going to work on a temporary basis, and they're not going to provide long-term reduction in the brain swelling. So this will be only used as a bridge to more definitive management, which is more likely to be like a decompressive craniectomy. If you're going to use hyperosmolar agents like mannitol or hypertonic saline, you need to be aggressive with it. You don't give it as a slow infusion or give small bits and wait for it. You have to be aggressive. You have to give a big bolus of mannitol or hypertonic saline until you get a reduction in the brain swelling that you can actually examine, like the patients who have a reduction in the GCS, for example, because of the brain swelling. You can see some improvement in the GCS once you give them those measures with the mannitol or the hypertonic saline. But like I said, again, this will be only temporary and used as a bridge for further management. Well, what I usually say is you can repeat the doses of mannitol, and you can interchange them between mannitol and hypertonic saline. And I would say you can give mannitol up to an osmolar gap of 20 milliosmoles per liter. Hypertonic saline, again, can be given in boluses, and you can give it all the way up to a sodium of 160 milliequivalents per liter. And then what you would hope then to provide the patients with the treatment will be a decompressive craniectomy. It is a very effective way of managing brain swelling and reduces mortality and improves outcome, particularly in patients with malignant MCA infarctions. But there's some caveats to it. It is more effective if you do it early, and if you do it in younger patients, and younger patients meaning patients less than 6 years of age. If you do it late and you do it in elderly patients, you are likely to reduce mortality, but unfortunately, you are likely to have patients with quite excessive disabilities, and obviously the outcome of that will not be great. So decompressive craniectomy will be the go-to management in these groups of patients if they're eligible to it. In cases of cerebellar infarctions, suboccipital decompressive craniectomies should be considered. And if the brain stem is compressed and also causing obstructive hydrocephalus, as in obstruction to the flow of CSF, then ventriculostomy with an external ventricular drain will be recommended as again a temporizing measure until the swelling is reduced. And I think this will be the last thing to discuss: management of orolingual edema. This is not rare. When I was talking about this, people usually expect this to be a very rare occurrence. It is not rare. It's actually, I have seen it 2 times already in my sort of lifetime, and this means that it is not that uncommon. So you have to be very wary of patients developing orolingual angioedema following thrombolysis. So angioedema associated with TPA is a bradykinin-mediated angioedema. Patients who take ACE inhibitors are more at risk. If you do suspect the patient is getting worse, the edema is involving the larynx and the palate and the oropharynx with rapid progression, as you can see it progressing in front of your eyes, then you should very quickly try to intubate these patients using an awake fiber optic intubation technique. These edema, kinds of edema, are not usually expected to respond to steroids because they are bradykinin mediated, so they're not expected to respond to steroids or antihistamines or adrenaline. But most institutes that are still being widely used, so they will be given to most patients. There are a few drugs that you can give to treat this condition. One of them is a bradykinin receptor antagonist, which is called icatibant, which is a drug that can be given subcutaneously and repeated a few times. I don't think this is available in all institutions, but if it is available, it will be the drug of choice to use. Or C1 esterase inhibitor concentrates. These have been reported to have been used successfully in patients. But the most important thing, if a patient is developing life-threatening airway edema, then you would hopefully intubate the patient and support them. And with time, the edema will go down and the patient will be okay. So with these, we have discussed the most sort of common complications and the most common harmful things in the brain that you should try to avoid and treat. And with that, hopefully, you will be providing the patients with the best outcome following a thrombectomy. Thank you.
Thank you, sir, for this informative lecture, really. Dr. Zainab, do you have any comments, please?
Thank you very much for this really great and informative and very beautiful acknowledgement that you shared with us, Doctor. Thank you. I just wanted to highlight one point that our patients, all of them are admitted in the ICU, not because of having complications post management of stroke, but because our stroke unit is inside the ICU itself. So these patients are part of our patients, but separated in their beds, and we follow them and monitor them as part of our patients. Thank you very much.
Thank you, Dr. Zainab. Thank you. Dr. Ali Saad, manager of Iraqi Korean ICU Center. I don't know if he is with us or not. Okay. Now we move to question and answer section with Dr. Meena.
Thank you, Dr. Ali. Thank you, Dr. Mazen. Actually, we have some questions about the lecture. First question from Dr. Zainab. Should we depend on cut values of blood pressure rather than considering a percentage of increase or decrease blood pressure frame the baseline?
In terms of, okay, so when you are treating a big cohort of patients, it's obviously you need to have a target, because if you are treating, obviously individualized care is obviously the most accurate or most important thing for patients. But what you want to provide the patients with is a target for everyone to be able to aim for. So when we say things like targets of like 220 over 120, this provides like a ballpark figure for like residents and attending physicians to aim for when they are looking after these patients. When you have institutionalized sort of care pathways that give an outline for targets for patients management, it makes the management easier to achieve, and it makes it at least something that's obviously achievable and measurable as well. The individualized targets for patients is obviously much more correct, but what we want to aim for in these cases is obviously provide the best care for obviously the majority of the patients that come through the ICU. And again, these targets are I wouldn't say they are obviously fixed. If you feel that a patient will benefit from a lower blood pressure target for any specific reason, then obviously you would try to obviously use that target, but you have to obviously be able to justify your reasoning for it. I don't know if that answers the
Thank
question.
you, Doctor. نعم. The second question is from Dr. Akram. What is the role of anticoagulant in patient with stroke caused by active internal carotid artery thrombus? I think it's out of the scope of this lecture.
I think it is actually out of the scope. Like I said, it is. I am an anesthesiologist. I'm not a stroke physician. I do have an interest in stroke management, so I do listen to lots of lectures and I do read a lot of papers about what is obviously the best management for different kinds. And I can tell you, it is not straightforward. And what proves my point, I try to make myself feel better about this, is that a lot of times I see neurologists arguing about the management strategies for patients, for the same patients. So I know that this is not something that is set in stone. I think that's why I always refer to the neurology as a team to come up with decisions regarding the management of like antithrombotics and antiplatelets in stroke patients. And I wouldn't go any further into answering that question. Sorry.
نعم. Third question is from Dr. Zainab. Is there a rule of sedation for this patient, or it's preferred to keep them without sedation in order to keep following Glasgow Coma scale changes?
Yeah, okay, that's a very good question. So if a patient, it depends on the reason why you are intubating the patient. So if the patient is intubated and ventilated because they have a reduction of the GCS, then you would obviously would not want them to be sedated excessively, because you want to see whether they're improving or not, and whether they will be someone who's eligible for extubation or further management in that way. You would have to think that some of the sedation is required for tube tolerance, because obviously having an endotracheal tube is not very pleasant for anyone. So you'll have to provide some sedation for these patients, and you can, if you think that even that minimal sedation is providing enough interference with the GCS assessment, you can always do sedation breaks. So you can stop the sedation. What we usually do in the institutions that I worked in before, so you could do like a sedation stop in the morning. So by the time you do a morning ward round, the sedation would have obviously, hopefully, worn off by that time, and then you can do your assessment and see whether this patient is getting better or staying the same or getting worse or whatever. So again, this is very variable in different patients, but the core concept is obviously the less sedation, the better, for sure.
Yes. Other question from Dr. Ali Akram. Best sedative to use for mechanically ventilated patient with stroke?
Okay, again, I mean, this is very variable depending on what the situation is with the patient. So if you are giving sedation just for tube tolerance, then there are some medications that will help you. This things like opioids, like fentanyl or alfentanil, whatever you have in your institution, or some ICU units use remifentanil. There are units that use dexamethasone for again tube tolerance. What you don't want to have is high doses of like long-acting benzodiazepines, for example, that have a cumulative effect and will stop you from being able to assess the patients neurologically. Propofol is obviously another very commonly used drug, but again, what you don't want to do is excessively sedate these patients that you won't be able to assess them neurologically. So to answer the question, the best sedative is what is the best for the patient, and most of the time is the very minimal amount of sedation for tube tolerance, if obviously the reason for their intubation was neurological deterioration.
Yes. Other question is from Dr. Al-Shakarji. For orolingual edema, do you recommend doing TPA reversal?
TPA reversal with I'm not sure what TPA reversal drugs will be. Maybe there's something I'm not sure. I'm not familiar with. I mean, once you suspect there is TPA related angioedema, then if the patients are still receiving TPA, then you would stop it as soon as possible, and then you can give the drugs that I've discussed, like the C1 esterase inhibitor concentrates or the bradykinin receptor antagonists. If there are some other drugs out there that are used, then obviously I'll be learning something that I haven't been familiar with before.
Yes. Another question from Dr. Saad Karim. Please, would you prefer early tracheostomy intubated patient with stroke in ICU? I mean, after 10 to 14 days of intubation.
Okay, so the cohort of patients that will be going for a tracheostomy would be likely to be patients that are going for a long rehab journey. And if this is the case, then you would have to think whether a patient is eligible. You think the patient will be eligible for like a rehab treatment, and in that case, you would then think about an early tracheostomy. If there are any other reasons why patients is intubated, like for example, respiratory failure from aspiration or for temporary reduction of GCS, then I wouldn't recommend an early tracheostomy in these cases. Again, the majority of my responses to your questions are not clear-cut because the stroke patients are not like one cohort. They come in with completely different presentations, and their outcomes can be very variable. So you would have to individualize the care for these patients, and you have to think about what is the intended benefit out of tracheostomy. If it is for long-term rehab, then yes, I would suggest it would be an early tracheostomy would be recommended in that case.
نعم. Dr. Ahmed Sattar, he has a question. The mic is yours, Dr. Ahmed.
Assalamu alaikum.
عليكم السلام.
Doctor, thank you for all. I have a question about lock-in syndrome and how management and outcome in ICU unit.
Sure. So obviously, this will be another one of those controversial cases. So patient coming in, presenting with a posterior circulation stroke who have a brainstem infarction and locked-in syndrome. Obviously, patients would be not eligible for like death with brainstem criteria for any reason, because they are, for all intents and purposes, they are alive and they can communicate with you in some ways or the other. So the management in ICU will be like a very long sort of rehabilitation, if that's the correct word to use, management or palliative management. So these patients will have early tracheostomy. They will be either kept on ICU, or if you have institutions that can look after long-term ventilated patients, then they would be sent to these institutions for long-term ventilatory support. These patients will obviously need to be have the full package of care, like for example, like a PEG tube for feeding. They will need a suprapubic catheter for long-term catheterization, and they will just need 24/7 care. They will obviously not be patients that you would want to keep on the precious ICU beds for long-term. So we would hope that there are some other solutions or other institutions that will be able to look after these patients in the long run.
Okay, now other question from Dr. Hunar. What's the schedule for passive movement during and after risk period?
Sorry, can you repeat that again? Sorry.
What's the schedule for passive movement during and after risk period?
I think he want to talk about physiotherapy.
Physiotherapy. Okay. Yeah, I am not sure I'm able to answer that question. I mean,
Yes.
physiotherapy is it can be used as soon as possible after presenting with ICU. The first things that you do with patients presenting with ICU is to get a physiotherapist on board, either for respiratory physiotherapy or for musculoskeletal physiotherapy. I don't think there's a specific risk period for stopping physiotherapy from happening, apart from obviously the first few hours after thrombectomy, for example. You don't want to be moving the patient's lower limbs excessively in case you disrupt the clot in the femoral artery. But beyond the first 24 hours, I don't see any reason why the patient should not receive immediate physiotherapy if it was recommended.
Yes, I think now we have ended the questions. Thank you, Dr. Mazen. Very valuable information and lecture.
Thank you so much for having me.
Thank you, Dr. Ali.
Be with you.
Okay, thank you, Dr. Mazen. Thank you, Dr. Zainab. Thanks for everyone for your time and engagement. I look forward to continue the conversation, but time is up. We remind you to follow us on social media and to join our network if you don't yet. We are open to hear from you and to develop our work, and looking forward to meet you at the next meetings. Last and not least, we want to thank Norma Pharma for supporting this webinar. Have a good night.
Thank you.
Thank you, everyone.